How are you all? Sorry for yesterday's delay. Yesterday again was struck up there, so I could not continue. But today we are going to finish everything. Okay. So how are you all? I hope you are doing good. Good evening. Good evening. So as promised, we are starting class early. Having tea. Please join in. So we are starting the class. Speed is okay. Maybe some other issue. Yeah, I am all good. How are you all doing? So today we'll be learning about the nephrology. All doing. So today we'll be learning about. I don't know why is having some net issues. Now it's okay. Now it's okay. Okay. So there was some issue, I think. So now we have restarted. So it's okay now. So we'll be doing the remaining medicine now. Starting with the nephrology first. Hello Ramya, OP, all in one, Sandy, Nandini, Sagarika. Hello to everyone. So let's do the nephrology first. So I was at the topic of ADH. So let's move from there. So let's start. So as we have discussed that if there's a less ADH, it is called as neurogenic diabetes insipidus. And if there is kidney not able to, respond to the ADH, that's called as the resistance. Okay. And this is called as nephrogenic DI. So two kind of DI are neurogenic and the nephrogenic DI. Now features are obviously you cannot absorb water, so urine will come in the water will be coming in the urine. Polyuria, you are intensely thirsty, so polydipsia, plus also that is there. Okay, क्या बात है? Okay, best wishes Dr. Gulshan. Okay, I wish you all the best. Okay, love from Delhi to all over India. Yeah. Then urine will be having lower osmolality, but plasma osmolality increase. Remember always, if you lose water in the urine, the salt will accumulate in the body. So that's why plasma osmolality increase above 300. Books say 315, some books say even 313. So normal values 285 to 295, that is plasma osmolality. Investigation of choice, they say, is 24 hours water deprivation test. You don't give the water to the patient, still he is making hypotonic urine. Otherwise normal person should make hypertonic urine when you are water deprived. Now treatment. Neurogenic DI is desmopressin. Nephrogenic, we give thiazide. What is the reason? Thiazide initially causes water loss, and as there is a water loss, there is a compensatory increase in the sodium and water reabsorption. That will reduce the polyuria. Now remember, lithium induced DI, the drug of choice is amiloride, which is also drug of choice of Liddle syndrome. So remember, mnemonic Lilly loride, Lilly amiloride. So Lilly is used in two conditions, that is amiloride is used in Liddle syndrome and lithium induced DI. Now comes syndrome of inappropriate ADH secretion. Now what is the story about that? Here there is increased ADH above 5 picogram per liter. Could be because of tumors like paraneoplastic syndrome. They are the lung cancer which are making hormones like PTH, calcitonin, or it could be head injury, or sometimes even an adenoma in the pituitary can be secreting ADH. So that's why they all can cause excess formation, release of the ADH. Next question, causes more water absorption, so less urine volume, so hypertonic urine is there, but plasma specific gravity and the osmolality will fall. So remember, fall in the plasma osmolality is the hallmark, and it can be less than 280, and that is also causing our low sodium, that is hypo natremia occur. And when there is low sodium, there is a problem. It causes water to shift from the ECF into ICF, and this is via osmosis. And what is the result of this osmosis? It causes cell to swell and can cause edema and injury, especially to the brain. It causes what is called as central pontine myelinosis. Okay, investigation of choice is water loading test. So what are the tests we are doing? Water loading test we are doing. Okay, now what are the findings? It can cause, yes, paralysis, coma, death, all. Treatment is we give hypertonic saline to increase the osmolarity, that is serum sodium. So 3 or 5% saline is to be given. Then drug of choice is vasopressin antagonist called as Vaptan. So it is called as the Vaptans are given. They are Conivaptan, Tolvaptan, Mozavaptan. Okay. So we discussed the SIADH. Now GFR. What is GFR? Glomerular filtration rate. So how much is the GFR or the glomerular filtration rate? So it's approximately 125 ml per minute or 180 liter per day. What are the best for estimation? It is inulin clearance, MCQ, and clinically we use most commonly. So clinically we use mostly creatinine clearance. What we use? We use creatinine clearance. So clinically use creatinine. Why? Because it is already there in the body, it's endogenous. So that's why it's much easier to estimate or measure. So the easy method, it is our creatinine clearance. Okay. Now, what are the various formulas we use for the estimation of GFR? It is CKD-EPI, MDRD. They give you the estimated GFR, okay, which is corrected for age, race, gender, height, etc., etc. Are you clear? Okay, creating happiness, bhai, I will send it. So these are the equations like Cockcroft-Gault formula, in which they take 140 minus age into weight by 72 into serum creatinine, and again if female we multiply by 0.85, if not just remain 1. So that's why they're all different formulas which are used to drive the GFR. Okay, so I don't think they will ever ask you this in the exam. Even NEET PG, they've never asked the equations for GFR. Okay. Next question is, we also can study kidney using radioisotope based renal studies. So now what are the radioisotope based renal study? Let's see. First is DMSA, dimercaptosuccinic acid. It is for morphology. Remember, mercapto is giving morphology structure. Remember, so for the, if you want mnemonic, new mnemonic is diagnosis of morphology, structure, anatomy, go for DMSA. So morphology, structure, anatomy. So this is DMSA. You can see the kidney, you can see the, yes, calyces. So this shows you the kidney. Then if you want to go for the perfusion, blood flow and the functioning, we can go for DTPA or MAC3. So MAC3 and DTPA, they give you, they are very similar to our, what do you say, RAYU, in which we are checking the, yes, functioning. So here also we can function, check the function. If kidney is functioning and well perfused, you can see the areas of blood flow can be visible. Here the right kidney is getting the blood, but left is getting very little blood flow. So it indicates left kidney is not functional. So that is what is the DTPA is. So it gives you functional analysis. Okay. Now we'll discuss sodium transport. So remember, sodium balance. So what is sodium balance? Tubule absorb 19% of filtered sodium and less than 1% of sodium is excreted in urine. What is this 1% called as? It is called as the FANA. What is FANA? Is fractional excretion of sodium. Now remember, normal urine sodium is 10 to 20 nanomole per liter. If it become more than this, let's say more than 20, that is 30, 40, 50, or the FANA, which is the fractional excretion of sodium 1%. Normally it is less than 1% is the normal FANA. But if there's a tubular lesion, kidney can't absorb the sodium, so FANA will increase. It will be more than 1% and urine sodium will be more than 30. So please remember what is the value. It is, yes, 1% and this. Then come our acute tubular necrosis. Most commonly it is caused by toxins and the drugs, very common. Okay, plus it is by ischemia and ischemia. So these are two main causes, ischemia, that is blood supply problem. So let's take an example. When you give someone NSAIDs, paracetamol, okay, they inhibit the COX and decrease the prostaglandin level. which cause renal vasoconstriction, also seen in shock or other disease which affect the blood supply. If kidney tubules are not getting blood, so obviously there is a necrosis of the cell, and if the tubular cells are necrosed, they cannot absorb the sodium. So sodium will be lost in the urine along with other solutes, and that cause polyuria, natriuresis, also loss of fluid, and that causes increased urine sodium, and also FANA become more than 1%, can be 2 or above. So that is the finding. FANA will increase. FANA will increase. Okay. Chalo. Hello everyone. Hello Abhishek. Okay. Now, what are the management? So first is stop the agent or the drug. Correct the cause. If the cause, it can be correct like blood supply. If kidney is hypoperfused, you can correct the blood supply. We can give dopamine for renal vasodilation. Also, we can use the antidote. Antidote will correct the problem. What is that? N-acetylcysteine. So what is that? N-acetylcysteine. Paracetamol antidote. Okay, so that is N-acetylcysteine. Then there are two type of causes. One is ischemic causes, other is toxic, which I discussed. Toxic could be endogenous like myoglobin in crush syndrome, myoglobin damage the kidney, or hemoglobin in various kind like hemoglobin urea. And exogenous are drugs in which very common are our which one? Yes, NSAIDs. Okay. Next question, ischemic. In ischemic, there is the acute tubular necrosis. So acute tubular necrosis. So first is there's a decreased blood volume that cause the decreased blood supply to kidney and cause ischemia. Plus could be diseases of renal blood vessel like polyangiitis or hemolytic uremic syndrome or our purpura. Okay. Now we'll discuss acid-base balance. So please remember acid-base balance. Tubules are the one which prevent the acidosis by causing what? Bicarb reabsorption, and they will remove the acid in urine and regain the bicarb. So very simple, they remove the acid and regain. That is why they are preventing the acidosis. So what are the enzyme they need? Carbonic anhydrase. And which area urine become acidic? In the distal tubule. So distal tubule, urine become acidic. So urine acidification occur in distal tubule. What is the minimum pH we can create? Up to 4.5. That is called as limiting pH. Now aldosterone help in acid secretion. Okay. So now what happens is, if there is a tubular lesion, kidney cannot secrete the acid. So there is a bicarb loss, and bicarb loss causes metabolic acidosis. So low bicarb is metabolic acidosis. So that's why it causes a metabolic acidosis because of loss of bicarb, and because the tubules are the one responsible, it's called as RTA. What is RTA? Renal tubular acidosis. Now, loss of bicarb in urine is also called as bicarbonate urea. What is the term used? Bicarbonate urea. Next is renal tubular acidosis, RTA. It is a normal plasma anion gap is there. That's why called as nagma. Nagma is RAD. Remember mnemonic RAD? Nagma, RAD, RAD. What is RAD is? RTA. Then it is A for Addison disease, A for our acetazolamide, D for diarrhea. तो राड इज नगमा, बाकी सारे हगमा. सो रिमेंबर नगमा राड है, बाकी सारे हगमा है, अदर्स आर हगमा. नाउ देयर इज अ इंक्रीज इन द यूरिन anion gap due to ammonia, and now there is also potassium loss in RTA1 and 2. So remember, nagma with potassium loss is RTA1 and 2. Okay. Now if there's a distal tubule lesion, it is called as DTA1, and if it's a proximal tubule, it is called as a RTA2. So RTA1 is DTA, distal tubule. RTA2 is proximal, PTA. So mnemonic is Delhi police. So when there is a road traffic accident in Delhi, what come? Delhi police come. And what is the mnemonic of Delhi police? First, 1 is D, 2 is P. 1 is D, 2 is P. 1 is D, 2 is P. Now RTA1 plus 2 combined is called as RTA3, which is mix. So mix is 2. And RTA4 is nothing but deficiency of aldosterone, which is Addison disease, which we have discussed already in what condition? Yes, yeah, the Ajay Devgan, Bolo Jaba, Kesari, Vimal. So we've discussed that already in medicine also and physiology also. Now treatment, drug of choice is hydrocortisone and bicarbonate. So we'll give bicarbonate to correct the acidosis. Okay, so bicarbonate is to be given. Good evening to everyone. Okay, next question that we can see is summary. Okay, so hyperkalemia is seen in RTA. This, so hyperkalemia. Okay, so if there's a hyperkalemia and decreased sodium, that is RTA4. So decreased sodium and increase potassium. That is RTA4, okay, hyperkalemia, okay, decrease sodium, increase. And in hypokalemia, there will be hypokalemia, RTA1 and 2 hypokalemia. Now check the urine pH. If the urine pH is more than 5.5, it is a loss of acidification, it is RTA1. If pH is less than 5.5, that means acidification is working, then we go for RTA2. So let's see the table first. Okay, we'll do it later, don't worry, Dr. Krishna, we'll do it later, okay, don't worry, okay. So let's discuss. So PCT damage is seen in the Fanconi, which I'll discuss now. First, RTA1 is a distal tubular lesion, whereas RTA2 is a PCT lesion. Example, Fanconi syndrome. So will be counted in RTA2. Are you clear? Now, other name is, it's distal tubular acidosis, proximal tubular acidosis. So who acidify the urine? It is distal tubule, so it's lost, it cannot acidify. So urine pH become high. So increase urine pH more than 5.5. So the urine pH, it become more than 5.5 in distal tubular acidosis. So which condition? Distal tubular acidosis. Whereas less than 5.5 in RTA2. Why? Because proximal is damaged but distal is working. That's why there's a good acidification and the pH can become what? Normal in this case, okay. Then renal stones occur because what? Whenever there is a pH, high pH trigger precipitation of what? Renal stones due to calcium binding to the alkali, citrate or other stuff, oxalates, and that causes more renal stone. Whereas less stones in acidic urine of the RTA2. Finally, there is bicarbonate urea, that is loss of bicarb in the urine. Less than 10% is in, yes, distal tubular DS, distal tubular. More than 15% in the, yes, proximal tubular. And glycosuria is present in distal or proximal? Proximal, because who reabsorb the glucose? It is our, yes, proximal tubule. So that's will be seen in the proximal tubule but not in the distal. And finally, treatment is hydrocortisone, then potassium bicarb. Here again we give potassium bicarb but more, because of severe hypokalemia we give more potassium and more bicarbonate. So that is the treatment of choice, okay. Chalo. Now we'll discuss the azotemias. Now what is azotemia? It's again, I told you, kidney diseases. Now it could be pre-renal, renal, that is intrinsic, which we have discussed already yesterday, and post-renal. Now what is post-renal? It is problem affecting the urine outflow. Obstructions is there, so obstruction. Now remember, technically renal, post-renal have similar features. Reason? Because once there is an obstruction, tubules are damaged because of accumulation of toxins in the lumen. So that is why the features are same. So whatever features are there in RTA, intrinsic and the post, they are same. See, 20, 10, 10, 30, 30, 1, 1. So everything is same. So that's why features are same. So let's start. First is in a pre-renal, which is due to kidney blood supply problem. The kidney is working, trying to work as best as possible. That's why concentrated urine is formed. So what is formed? Concentrated urine is formed. Whereas in the case of intrinsic or renal, they fail to concentrate the urine. That's why we get what? We get a dilute urine less than 350 milliosmol per liter. Clear? I am good, Dr. Ainuja. Okay. Then same way. Here urine contain more salt, it's concentrated, so contain more salt, more solute. That's why it's heavy, more than 1020. Here the urine is light, less than 1020. Then FANA, kidney absorb the sodium very well, so that's why it is normal. Normal, tubules are normal, so less than 1%. Here tubules are damaged, so more than 1%, more than 1%. Urine sodium will be less than 10 to 20, so it's 10 to 20. Here it will be more than 30. I told you kidney will lose the sodium. Then it will again be less. So it will be less than 10 or 20 milli. Then what happens to the kidney creatinine ratio? So kidney will excrete the creatinine, so it will be high ratio. Then burn will be high, burn creatinine ratio will be high. All three are high, but they are less. So remember the mnemonic. All parameters low in intrinsic and post-renal. All parameter, creatinine, burn creatinine, urine osmolarity, all are low. But FANA and urine sodium are high in them. Okay, urine sodium high. So please remember, all parameters are low. What is high? FANA and urine sodium are high. MCQ. What is high? So please remember this topic, because I'm not joking. This has been asked in the exam, and then you will not be able to remember anything. They'll ask you what will happen to the burn creatine ratio. You'll say, I don't know. I told you very simple mnemonic. Every parameter is decrease in intrinsic and post-renal, and they are high in case of pre-renal. Only two things are low in the case of pre-renal, that is urine sodium and the FANA. So they are low in pre, others are high. So that is one line summary. Hello Dr. Akshay. Okay. I think we have discussed that already. Okay, Ionja. Okay, I think Ioniza. We have already discussed that. If there's an issue, I will again re-explain. Okay, at the end. Okay, chalo. Now come our disease called as acute renal failure. What is it also? Hello, Dr. Afifa. What is it also called as acute kidney injury? What is acute means? Less than 3 months. If more than 3 months, it become chronic. What are the classification? We use something called as rifle criteria. MCQ. What we use? Rifle criteria. What is rifle? Risk, injury, failure, loss of function, and end stage. So please remember, risk, injury, failure, loss, and end stage. Loss and end stage. Let me show you. So this is the rifle criteria: risk, injury, failure, loss, and end stage. Risk, injury, failure, loss, end stage. This is called as rifle. Let me make it easy for you. So remember, first is failure, then loss, then end stage. So remember, loss, how many letters are there? 4 letters are there. LOSS. So that criteria is similar. It is 4 months. So if there is more than 4 months of acute renal failure, if there is more than 4 weeks, 4 weeks, it is called as loss. If more than 3 months, it is end stage. So remember, end has 3 letters. 1, 2, 3. So 3 letter. So it is 3. So it is 3. So remember, more than 3 months is end stage, more than 4 weeks is loss. Okay, so end stage kidney disease. So end stage kidney disease. Okay, treatment is renal dialysis. Okay, treatment is renal dialysis or transplant. So what do you do? Renal dialysis or transplant we do in case of end stage kidney disease. Okay, now remember, for RIF, please remember three criteria: decrease GFR, increase creatinine, and decrease urine output. So let's learn with me. GFR 25, 50, 75. 20, 50. This was asked in 2021 FMG exam and 2018 NEET PG also. So please don't ignore it. So GFR decrease by more than 25%, 50%, 75%. So let's revise it. So what are the criteria for GFR? Let's learn it. So GFR criteria: 25, 50, 75. So 25, 50, 75. So 25, 50, 75. Okay. So what is 25? Risk. 50% percentage is percentage, and this is failure. Easy. Then creatinine, serum creatinine, very simple. It is into 1.5, into 2, into 3. So these are the value: 1.5, 2, 3. So 1.5, 2, 3. 1.5, 2, and 3. So 1.5, 2, 3. Okay. And then urine output. Urine, I told you it is ml per kg per hour. So remember, 0.5, 0.5, 0.3. So 0.5, 0.5, 0.3. 0.5, 0.5, 0.3. So less than 0.5, less than 0.5, less than 0.3. So 0.5, 0.5, 0.3. So that is the one. So 0.5, 0.5, 0.3. Clear? Okay. Okay. Now let's move. For 6 hours in risk, 12 hours in injury, and 24 hours in failure. Now what are the clinical features? So obviously if kidney fail, urine will decrease. So there is a oliguria and anuria, especially in shock, etc. Then uremia causes uremic encephalopathy, where the patient has the neurological manifestation like confusion, memory loss, delirium, tremor, coma, all. Then there is also uremic pericarditis, palpitation, heart failure. So again these things occur. Then also urea get precipitated on the skin, which create urea crystals and which look like snow. So it look like snow or frost, called as uremic frost. Okay. Then skin become dry, itchy, and smell is urine like smell. So urine smell from the skin is seen. Then nausea, vomiting, abdominal pain is there. Okay. Then hyperkalemia, because kidney cannot remove the potassium. Metabolic acidosis, again tubule fail to remove acid. This is HAGMA, high anion gap metabolic acidosis. So high anion gap metabolic acidosis. Then anemia occur because kidney is the one which make erythropoietin. Without erythropoietin, you cannot do the RBC production properly. Then osteoporosis. Why? Because kidney is losing calcium phosphate. Osteoporosis occur. Then there is also going to be what? Increase in the uric acid. So that causes gout. So increase uric acid because kidney cannot remove it. Gout can occur. Then if it is pre-renal, that is problem is blood flow, we can see shock-like feature, decrease BP, decrease JVP, heart rate will increase. But if it is post-renal or renal, then volume is increased. Why? Because kidney cannot make the urine, so volume accumulates. So now you can see, okay. Hello, Dr. Saab. Okay. So now there is volume overload, edema can be there, mainly facial edema. Remember, kidney diseases mainly manifest with facial edema. Left heart failure, pulmonary edema. Right heart failure, pedal edema. Okay. And mixed edema, hypothalamic, generalized edema. Remember them. Okay. Then come heart failure, hypertension, all. So hypertensive crisis, remember I discussed in CVS, can occur in our kidney disease. So kidney disease, we might get our hypertension. Then come our osteoporosis, we discussed already. Okay. Reproductive system, what is the story? Is less steroids, that is why it causes ovulation failure. Then failure or oligomenorrhea, amenorrhea, loss of libido, impotence, all will occur. Why? Because, hello bhai, Dr. Ved Prakash, Dr. Gautam, how are you all? Okay. Now investigation, obviously we do kidney function tests, we do MAC3, DMSA, new markers like Angal, cystatin D, all are checked. GFR we need to check all. Okay. Then we do urine examination for proteinuria or some cast, hematuria or any kind of pathology. Okay. Now treatment is always correct the underlying cause. Remember, in medicine the theory is simple. We should never treat the symptoms. We should always treat the disease which is causing the symptom. Okay. Then fluid and electrolyte correction. Okay. There's a hypovolemia, need to give the fluids, or hyper, you might give diuretics etc. to remove the fluid. Acute pulmonary edema, we give what? We give furosemide. Then diuretics to increase the urine output. Okay. But they are not used in pre-renal failure because there's a low volume. So that's why treatment is the main thing. Okay. If there's a shock or some vascular disease, we need to correct the blood flow, not give drugs which are increasing the urine output. Okay. Then ACI, ARB, they basically to correct the blood pressure, volume overload. Okay. Then we give erythropoietin because we need to make the RBC. So erythropoietin for anemia correction. Metabolic acidosis, we treat with bicarbonate. So we treat with bicarbonate. So dialysis is the mechanism here. Then also we have the correction of hyperkalemia. So if there are ECD changes present, we first give calcium gluconate which stabilizes the membrane. Then we give insulin and beta-2 agonist salbutamol. If doesn't work, we go for dialysis. 100% exam question. Hyperkalemia, start with calcium gluconate. Then we give insulin and beta-2 agonist, and then we will go for dialysis in case they are not sufficient. Okay. Now also we have to correct the hyperuricemia by giving allopurinol which inhibit the xanthine oxidase. Acute gout we go for NSAIDs. Chronic gout we go for allopurinol. So chronic we go for allopurinol. Also we need to correct the calcium and phosphate, vitamin D supplement. They are needed for the correction of osteoporosis. Then if there's a scleroderma crisis, a person with scleroderma, again what happens? There is a very high blood pressure. So again kidney failure can occur. We are giving ACE inhibitors. Okay. And rhabdomyolysis, breakdown of the muscle, we give force alkaline diuresis basically so that we can remove the especially myoglobin. Okay. Dialysis. Okay. What is dialysis? So dialysis is the last choice. Okay. It's done in very few condition. IU, AEIOU, AEIOU, which I'll tell you very soon. So done in AEIOU, which we'll discuss. Now tumor lysis syndrome. If there's a tumor lysis syndrome, there is lysis of tumor and that release lots of uric acid that cause hyperuricemia, and the drug of choice we give rasburicase. What we give? Rasburicase in case of tumor lysis syndrome. Okay, very commonly asked questions. This is a rifle criteria I've discussed already. Now what are the indicators of dialysis? So they are AEIOU. A for acidosis. Which acidosis? Refractory acidosis, which is not corrected even after giving bicarbonate. So we are giving bicarb, it should correct the acidosis, but it's not corrected. We should go for our dialysis. Then electrolyte imbalance like refractory hyperkalemia or any other like electrolyte imbalance which is not getting corrected, then we have to go for our dialysis. Intoxication. Okay, so that's why drugs like barbiturate, theophylline, aspirin, INH, lithium, they're very toxic. And if there is too much level in the body, we need to remove with the help of dialysis. Then edema, which is again very severe refractory like acute pulmonary edema with severe dyspnea or uremic pericarditis and encephalopathy. Then we have to remove them using what? So all this waste should be removed, urea etc., using dialysis. So for dialysis, if you want repeated long-term dialysis like in kidney failure, we might create a AV fistula. It takes months to repair and heal. So we create a arteriovenous fistula. For short-term basis, we can use the bridge or the graft, AV graft, or we can use a central venous catheter. Okay, so these are for emergency basis. Okay, chalo. Okay, Nishant, we will update it soon because of some issues. There will be up and down. So we'll be correcting it soon. Don't worry. Okay, so we'll correct it soon. Now, new markers of kidney disease. So what are the new indicator? One is KIM. So remember KIM, kidney injury molecule 1. Then we have the cystatin D. So what we have? Cystatin D. Then ANGAL. What is ANGAL? It is from neutrophils. We have interleukin 8 also, and we have L-type fatty acid binding protein. So L-type fatty acid binding protein. Now there's a condition called as hepatorenal syndrome. Remember, hepato means liver, renal means kidney. So remember, it's a kidney failure secondary to liver disease like cirrhosis. So what happens is there's a kidney failure. What is there? Decreased GFR, decrease in output, increased creatinine, but there's no morphological defect because kidney is structurally okay. Problem is the blood flow affected. How? Cirrhosis. There is a RAS overactivity whenever there's a kidney liver disease. So it causes portal hypertension because of cirrhosis, which causes GIT and splanchnic vasodilation that lower the BP. Lower BP releases renin, and renin then increase aldosterone angiotensin, and as there is increased aldosterone angiotensin, what they do? Also they will cause renal vasoconstriction via angiotensin 2. And as there is a renal vasoconstriction, kidney doesn't get the blood, which cause the hepatorenal syndrome. Okay, again it's a type of ischemia. And also there is a high renal sodium ability, so sodium is accumulated. So this increased sodium causes fluid in the abdomen called as ascites. Ascites is a mark of cirrhosis. It's a mark of cirrhosis. Okay. Now management is obviously treat the liver disease, okay, and manage renal failure by ASCI or ARBs. Okay. Now come chronic kidney disease. So what is chronic is if the duration goes more than 3 months, it is called as chronic. There are two criteria: decreased GFR, so less than 90, and albumin urea more than 30 milligram per day. So let's revise it. I'll make it easy for you so that you don't have to forget. Remember, see, 90, 60, 30, 15. That's it. So 90, 60, 30. So how to remember? Less than 90, less than 60, less than 30, less than. So if it is above 90, it is 1, this is 2, this is 3, this is 4, this is 5. Very easy. 5 is failure. So what is that? This is 0 to 15. This is what? So 0 to 15. Okay. Yeah, 14 actually. This is 15 to 29. This will be how much? It is above this. So 30 to 59. This is 60 to 89. And this is the case. So remember, if less than 90 but above 60, it is mild or grade 2. If it is less than 60 but till 30, it is grade number 3. Then come grade number 4. It is 15 to 29. So 15 to 29 is grade number. And finally, yes, 0 to 14. 0 to 14 is also the value. 0 to 14. So clear? Let's start now. So now we see albumin urea. So there is a protein urea more than 30 milligram per day. How much? More than 30 milligram per day is our albumin urea. Grade 1 is less than 30. Grade 2 is 30 to 300. Grade 4, spelling is wrong, is more than 300. That is grade 4. What is the ratio? It is A is albumin serum creatinine ratio. Okay. Now causes. Most common cause, overall most common is diabetes mellitus, which cause the chronic kidney disease. And the specific diseases Kimmelstein, Wilson, nodular glomerulosclerosis. There is hyaline deposit, plus there is, yes, increase, we will say, damage to the glomerular capillary, and there is protein urea, especially microalbuminuria is the earliest feature, more than 30 milligram a day. Plus there is polyuria initially, then there is oligouria later on. Okay, so initially polyuria, then oligouria, also there is protein urea, and decreased GFR later on. Okay, so initially what will happen? Initially there is polyuria, then oligouria. So are you clear? Hypertension. It causes malignant nephrosclerosis, which cause flea, beaten kidney, which we have discussed already. Then chronic UTI or obstruction can also cause the CKD. Polycystic kidney disease again can cause chronic kidney disease. So all of these are causing kidney diseases. Are you clear? So they are causing our kidney diseases. Next question. How do you manage? It is very similar to ARF. So is it different? No. It is similar to our ARF. It is our similar to the ARF. Now what is the funda about the ARF? First, we control the BP. So drug of choice is ACI or ARB. Then we correct our blood sugar level. How? By OHA, oral hypoglycemic agent. Insulin is needed for that. Correct hyperkalemia, acidosis, can go for dialysis if nothing is working. Then protein salt restriction. Why? Less urea and sodium. So that's why protein and salt should be restricted. So we should decrease the proteins and also the salts. Okay, so that is the story here. They should be reduced. Then allopurinol. So what is also there? Allopurinol is also there. So allopurinol. Okay, it is for gout treatment. So what is allopurinol? It is for treatment of our gout. Allopurinol. Okay. Next question. Erythropoietin. It is basically for anemia correction. So anemia correction. Next is also we can give calcium and phosphate supplement. So calcium and phosphate supplement. Okay. Then vitamin D also for osteoporosis. Later we can go for dialysis or renal transplant. So these are the other findings. Okay. Next question. Okay. This is the stages: normal, mild, moderate, severe, failure. Failure less than 15 GFR, it is 15 to 29, it is 30 to 59, it is 60 to 89, and this is above 90 GFR. This is GFR above 90 GFR. So clear? Now, tubular disorders. What are the various tubular disorders? We'll start with our number one. Number one is our Liddle syndrome. Autosomal dominant. First, it's autosomal dominant AD, and there's a mutation in the beta units of the ENaC. So what is the mutation? Beta and gamma units of ENaC. It prevents the breakdown of ENaC, so effectively making more ENaC activity. So what is high ENaC activity seen in? So it is seen in which condition? It is seen in our Liddle syndrome. So that causes more sodium reabsorption. That's why it resembles cone. So what is like a copy of the cone? It is Liddle is a copy of the cone. Then hypernatremia, hypertension, metabolic alkalosis, hypokalemia, they all are also occurring. So what is there? Hypernatremia, hypertension, metabolic alkalosis, hypokalemia, they all are also present. But remember, normal or decreased level of aldosterone. So what is there? There is a normal or decreased aldosterone, therefore rather decrease. Hence, Liddle syndrome is called as pseudo hyperaldosteronism. So remember, if you get a patient with high sodium, low potassium and more aldosterone, it is cones. If there is low aldosterone with high sodium and low potassium, this is our Liddle. So Liddle में क्या होगा? आपका aldosterone कम होता है, and अगर aldosterone is more, it is cone. So remember, increase aldo cone. Okay, I'll give the summary later. And that is the case. Drug of choice is amiloride, which I told you, lilliloride. Next question is Bartter syndrome. It's autosomal recessive, AR. In fact, even this Gitelman is autosomal recessive. It resembles drug loop diuretic because there is a Bartin gene defect which affect the activity of thick ascending loop transporters like NKCC and ROMK also, ROMK and ROMK. These are affected in this case. Now what is that? It is thick ascending loop of Henle sodium potassium chloride co-transport. So there is a loss of all possible solids. So almost everything is lost. Water, sodium, all are lost. So there's a hyponatremia, hypokalemia, hypocalcemia, hypochloremia. Everything is lost. Everything is lost. Also, there is a decrease in serum magnesium and decrease in serum phosphate also. Everything is decrease. Everything is decrease. Okay. Also, there is a failure to concentrate the urine, which is giving you isotonic urine. You can't concentrate. You are losing everything. And there is an increased expression of prostaglandin E2. And that is why we give drugs to block the PGE2, like what? We are giving the endomethacin. Then there is a chloride resistant metabolic alkalosis. What is there? Chloride resistant metabolic alkalosis. Clinical features, since it's a genetic disease, so early life, okay, children is present. There's a polyuria, polydipsia, hypokalemia, muscle weakness, wasting, poor growth, plus sensory or hearing loss because of low potassium, plus rickets because of low calcium, all are there. Treatment is first endomethacin to block the PGE2, which is involved in kidney functions here. ACE inhibitor or ARB are given, okay, electrolyte supplements, renal transplant. So the final treatment will be renal transplant in this patient. Okay, renal transplant is the final treatment. Now come Gitelman syndrome. So remember, Gitelman resembles thiazide. So it resembles what disease? Thiazide. So autosomal recessive, this is what it is, autosomal recessive. AR again, defect in NCC, sodium chloride co-transport in the early DCT. All are exam question. They give you photos, they ask you to identify. Again, loss of most of the ions in urine except calcium. There is rather a increase in the calcium. So what is there? Not decrease, but rather a increase in the calcium take place. So there is a increase in the calcium. And what is there? Decrease in the urine calcium. So it is a, yes, decrease in the, see, Fanconi will also be having a loss of glucose, etc. Okay, clear? Fine. So lose glucose, etc. So almost everything that is lost is very, very similar to the patient. Okay. So are you clear? So that is the funda. Okay. So remember, Bartter is loop of Henle, and what is the Fanconi? Fanconi is PCT disorder. Fanconi is our PCT disorder. So that is one difference between the two. Clear? Okay. And remember, again, there is loss of amino acid also, glucose also, proteins also, RTA is there. Which one? RTA 2 will be there. So these are the differences between the two. Okay. Let's move. Next is there's a loss of all iron except calcium. So that's why one major difference is increased serum calcium is seen in case of Liddle or Gitelman. Answer is Gitelman. Okay. Whereas in Bartter, calcium will also be low, phosphate low, magnesium low. Okay. Urine calcium will decrease because calcium is absorbed more, so it's not lost in the urine. And it is different from Bartter because there is a normal PGE2. So there's a normal PGE2 and calcium level are increased. That is how you differentiate. I'll give a summary, don't worry. Okay. Treatment is similar to Bartter, but no need to give indomethacin or calcium supplement. What is missing? Yes, indomethacin and calcium supplements are missing in this case. This we have discussed already. This is the NCC, sodium chloride importer. Also, diagnosis is there is increased thirst. Why there is an increased thirst? Increased thirst because of what? Because of a very, very important thing. Loss of sodium, salt craving is there again, polyuria, nocturia, hypotension, all because of less sodium, muscle weakness because of what? Yes, our potassium loss. Okay. But remember, findings. Everything is less, but calcium is more. What is more? Calcium is more. आगे चलते हैं. Next question. Liddle syndrome. What are the finding about the Liddle syndrome? It is like cones, but low aldosterone. Okay. Bartter syndrome, NKCC, all are low. Gitelman, all low, but calcium high. All low, but calcium high. Okay. Yeah, isotope again are not used in Gitelman. Yeah. Chal. Now we'll discuss the most famous disease, that is our glomerular disease. It is 100% exam question, will be asked without any doubt. So let's start. First question. What are the funda about glomerular diseases? So first is, remember, there is nephritic syndrome and nephrotic syndrome. So nephrotic and nephritic. So remember the mnemonic. Nephritic, free, French fries. French fries increase the BP and it always come with Coca-Cola. So what is French fries accompanied with? Yes, drinking of Coca-Cola. And remember, the urine is Coca-Cola, reddish brown urine. So that's the two mnemonic, French fries or Coca-Cola urine. So what is that? It is Coca-Cola urine. Okay. So now, if there is mainly or only, what is there? Mainly or only proteinuria, suspect what? Proteinuria. Suspect our, yes, nephrotic syndrome. There is no hematuria, no hypertension. If there is hypertension, Coca-Cola, red urine, RBC cast, then suspect nephritic syndrome. Next question. There is more proteinuria, more than 3.5, called as gross proteinuria. What is it called as? Gross proteinuria. So gross proteinuria. Here is subnephrotic. Here it is subnephrotic, less than 3.5. Less than 3.5. Also there is selective proteinuria. Okay. mainly albuminuria, and here it is non-selective. Here is non-selective. Other proteins can also be lost, so non-selective. Then there is also lipiduria or lipoid cast. Okay, dyslipidemia is a hallmark. They are not much here. Okay, then loss of protein C and S, which are preventing the thrombosis. So as you are losing them, there is a high risk of thromboembolism. So किसमें होता है thromboembolism? Yes, it is in nephrotic mode. Pure immunity, increased infection, poor growth, again very commonly seen in the nephrotic, and there is edema mainly. There is less edema. Plus treatment is same. What is that? We give steroids in both. If doesn't work, we give immunosuppressants and dietary supplements. So dietary supplements are needed. So what do you give? Dietary supplements. So dietary supplements. Okay. चलो आगे चलते हैं. Steroids. Also there is steroids and ACI and ARB for hypertension plus immunosuppressants. So this is the case. Now let's start. Minimal change disease. So now what is the story about the minimal change disease? Mainly idiopathic. So they are mainly what? Idiopathic. Okay. Autoimmune, that is related to other autoimmune diseases, infections, drugs, even sometimes neoplasia are related, but mostly it is idiopathic. That means we don't know the exact cause. Now what is the pathophysio? This is damage to podocytes of the kidney, which are the Bowman capsule cell, and there's also loss of negative charge in the basement membrane. This causes the loss of negatively charged albumin, and that causes the proteinuria, albuminuria, which is the main loss. Then there are three. First question, when you do a normal microscopic examination, you don't see much changes because the changes are very small. That's why when you do a biopsy and do normal light microscope, you see almost no changes. That's why it's called as minimal change disease. Why? Very few findings are seen. But if you do a electron microscope examination, you see effacement of food processes, that is destruction is there, plus microvilli formation, and also vacuoles are formed. Let's see. This white structure is called as a vacuole. So this white structure is called as a vacuole, and these structures which you see, these are the microvilli. So these are the microvilli which are formed. So microvilli plus what? Microvilli plus our vacuole plus the effacement of the food process is the hallmark under electron microscopy. Chalo. What are the clinical features? So clinical features are basically young child, ages 5 to 15 years. What are the ages? 5 years to 15 years. Presents with edema, periorbital swelling. Also there is a decreased plasma albumin. There is muscle wasting. Then there is poor growth. Thromboembolism is there. Thromboembolism. Okay, all are there. Plus we check urine protein, they are very high, more than 3.5 gram per day, and there's a decrease in the serum albumin. Edema is there, mainly periorbital facial. Lipid profile is deranged. Urine cast are present. They are all finding of nephrotic. Treatment is drug of choice is prednisolone, 1 to 2 mg per kg per day. So let's say the weight of the child is 20 kg, so we give 20 to 40 mg per day. Then if there's a resistance to steroid, then we go for immunosuppressant, like we can give cyclophosphamide, tacrolimus, azathioprine, or rituximab. Rituximab is a monoclonal antibody which lowers the immunity. So rituximab, okay, rituximab. And statins for dyslipidemia, protein supplements to correct the protein loss. Okay. Now adults have a similar disease that is called as FSGS. What is that? Focal segmental glomerulosclerosis. So it's focal segmental glomerulosclerosis. Okay. Similar to MCD, but here it is occurring in adults. So occurring in adults. So it is in adults. तो बच्चों में क्या होगा? Minimal change. Adult में FSGN for nephrotic syndrome. So again the changes are, there is a foci of hyaline deposit. You can see this. So hyaline deposit is there, pink color, you can see. Plus there is an increased matrix cellularity, more cells are there. Plus there is a collapse of vessel which is not uniform, not global, but some area. That's why called as focal. So segmental collapse of vessel and podocyte damage. That is the case. So you can see hyaline deposit, okay, pink color. So glomerulus increased matrix. This is a hyaline deposit is there. Plus there is also damage to podocytes and increase in the cellularity is there. So okay, so these are the findings that we see in the cases of our FSGM. Treatment is same. Steroid, if doesn't work, go for immunosuppressants. Then come very famous nephritic syndrome. Nephritic syndrome. Now remember, in case children love to play PlayStation. So PSGN. So remember, children love PlayStation gaming night. Okay, gaming all the time. PS. So that's why it's very common in children. So most common cause of nephritic syndrome in children is PSGN. Okay, what is PSGN? Post streptococcal glomerulonephritis. So first there is a streptococcal infection. So first there is streptococcal infection, pharyngitis, impetigo, any of the infection, and it can be caused by what condition? Can be caused by strep pneumoniae, pyogenes, viridans. Now once there is an infection, what is the next step after infection? After infection, after 4 to 6 weeks, there is a Coca-Cola urine, RBC cast, edema, but less edema is there, proteinuria, subnephrotic, less than 3.5, plus there is an increased complement protein, decreased complement protein, and there is increased ASO titer, which is also seen in rheumatic fever, increased ASO titer. And it's which hypersensitivity? Type 3 hypersensitivity with immune complex deposit and damage to the glomerulus. So there is a damage to glomerulus plus hypertension is there, which is a hallmark. Hypertension, Coca-Cola urine, go for nephritic. Children, it is PSGN. Okay. Treatment is we give ACE or ARV, steroids and immunosuppressants. If steroids are not working, antibiotics may or may not be used. Some books say yes, can be given, some say no. Now, if it's an adult, it is Berger disease. So adult, what do you see? We see Berger disease in the adult. What is the other name? IgA nephropathy. It is the most common cause of nephritic syndrome in the adult. What is that? It is Berger's. It's not Berger. Remember, if it is BUERGR, it is the one which occur in blood vessel. This is a vascular problem, smokers. So that is smokers, smoking, and there is artery become narrow. So don't be confused. That is a different. So Berger is smoking artery, smoking artery, smoking artery. Yes. Now next question. It is similar to PSGN in terms of upper respiratory infection can be there. Hematuria, proteinuria, hypertension, less edema. Biopsy is very important. You can see IgA deposit and crescent, cellular crescent. So it look like a moon, half moon with cells. So cells create half moon shaped crescent. That is the hallmark. With immunofluorescence, you can see the IgA immunoglobulin deposition which can be seen. Okay. So that is the case. Treatment is obviously we are going to go for ACE ARV for hypertension, steroids and immunosuppressants. So which is same as PSGN. So same as PSGN. Very special, Goods-Pasteur syndrome. Goods-Pasteur syndrome is a anti-GBM, antibody syndrome. What is GBM? Is glomerular basement membrane antibody, and mnemonic is what? 1, 2, 3, 4. So understand. So it is 2, type 2 hypersensitivity, SLE is type 3. Then it is against alpha 3 chain of type 4 collagen in the basement membrane. So 2, 3, 4. So type 2, 3 alpha and type 4 collagen. These antibody damage the lungs and damage our kidney. If it damages the kidney, there is hematuria. If it damages the lung, it causes the hemoptysis. So agar patient आया with blood in the sputum and blood in urine, it is Goods-Pasteur. तो कैसे याद करेंगे? G for glomerulus, G for glomerulus. Okay, glomerulus खराब है, P for pulmonary, lungs भी खराब है. तो GP में क्या है? Lung भी खराब है. So pulmonary means lungs, G for glomerulus. So remember, glomerulus and pulmonary, double problem. So glomerular and pulmonary lesion is your Goods-Pasteur syndrome. Okay, so destruction of glomerulus, hematuria is there, and it's a nephrotic syndrome. Why? Because there's a hematuria. Then RPGN is rapidly progressive glomerulonephritis. So what? It is rapidly progressive glomerulonephritis and what? Renal failure and what? renal failure. Okay. Also, there is hemoptysis, pulmonary basement membrane damage. So what damage? Pulmonary basement membrane damage. What are the damages? Pulmonary basement membrane damage. Treatment is similar again. Why ACI, steroid, immunosuppressants are the treatment. Okay. So this is the nephrology. All we have covered. Medicine summary is there in this table. You can see all less than 10-year adult. It is all. So this is all there. You can revise it with the help of this. Just remember, if it is our MGN, membranous glomerular, then we see the spike and dome. So we can see the spike and dome, that is there. Okay. So as a summary, everything is here in nephrotic, nephritic syndrome. Okay. So let's do the kidney now. It's over. Now we'll do the respiration, and then I'll end the medicine and start with ophtha, surgery, OBG, PSM. That's our target. We should finish these subjects. Which one? Ophtha, medicine, OBG, PSM. These four are the target for the next week before the 18th or 19th. We should be doing this. Okay. So let's start the respiration. So hypoxia I've already covered in the topic of where have I covered the hypoxia? I've covered that in physiology, so I'm skipping it. So discuss it. Cyanosis also we have covered. So just remember, cyanosis is bluish discoloration of skin and mucous membrane due to increase in the deoxy-reduced hemoglobin or a fall of SpO2 saturation less than 75%. It is absent in anemia because there is very less hemoglobin to cause the reduced hemoglobin becoming more than 5. Plus histotoxic because the tissue are not able to use the oxygen, so there is less reduced hemoglobin formation. Okay. Then there is cyanosis. Cyanosis, basically what happens? It is seen on face, lips, tongue, etc. and we get hypoxic hypoxia. So what do we get? Hypoxic hypoxia. Peripheral is seen in the palm, sole, fingers, that is peripheral, mainly seen in stagnant hypoxia. So if stagnant hypoxia, blood flow problem, may be peripheral. If hypoxic hypoxia, may be lung disease, it is central. So this is the case. This is hands, so peripheral. This is mouth, tongue, lips, it is central cyanosis. So Renal disease is basically asked multiple times. It could be primary, secondary. So there's a vasospasm on exposure to the cold. Female more common than male. So initially there will be whiteness because of vasoconstriction, less blood, pallor is there. Then it become blue because of hypoxia, reduced hemoglobin, which cause the bluish color. Later congestion occur because of vasodilation, more blood flow. So WBC is the mnemonic. WBC. Kya hai mnemonic? WBC is the mnemonic for our Renal disease. WBC. Okay. Now drug of choice. For the drug of choice, we give CCB. What is CCB? Calcium channel blocker are the drug of choice for this. Now treatment. Avoid exposure to cold. So क्या avoid करना है हमें? Exposure to cold should be avoided. Then caffeine and stop smoking. So also avoid exposure to cold. Then caffeine, also caffeine, and stop smoking. And also stop smoking. Okay. Then there is clubbing. Clubbing basically indicate a chronic pulmonary or cardiovascular disease. So chronic pulmonary or cardiovascular disease is there. So chronic pulmonary or cardiovascular disease. Okay. Now what do you see? Drumstick like finger, which is dilated distal part, and there's a very important sign called as Shamroth sign. There's a window sign. So you can do this. Make your fingers approximate. If you can see a diamond shaped space between this, it is indicative of normal lung function. But if it is gone, it indicate our it indicate our what? Clubbing. Okay. Shamroth sign. Now I'll discuss lungs give oxygen and remove the CO2. That is called as our ventilation. If there is a poor breathing, it's called as ventilation disorder. So oxygen cannot come, hypoxia come, CO2 can't go out. So carbon dioxide increase, hypercapnia occur. So if lungs are not able to breathe, it causes hypoxia and hypercapnia. Example, restrictive lung disease where you can't breathe. This discussed in physiology also. Severe obstruction like foreign body, tumor, COPD, asphyxia, choking, they all cause poor ventilation. So hypoxia with hypercapnia occur. Neuromuscular disease like Guillain-Barré, myasthenia, paralysis, all causes our poor breathing. So remember, if there's poor breathing, poor ventilation, there would be less PaO2 and more PaCO2. That's the hallmark. Diffusion is, please be positive, okay, don't be negative, okay, Dr. Owen. Life is more important than these kind of things. These things are like, you know, temporary, okay. Please focus on your life. Your career is the most important thing. Career hai to zindagi hai, kuch nahi hai varna, okay. Chalo, next question. Diffusion is basically oxygen from alveoli enter the blood. This is called as diffusion. Air entering the lung is called as ventilation, okay. So second disease are the diffusion disorder. If there's a diffusion disorder, the membranes are not letting oxygen go to the blood. That is why there is hypoxia and the person compensate by hyperventilation. So PaCO2 can decrease. I'll discuss it later. Now remember, what is the investigation of choice for diffusion disorder? DLCO. So what is that case? It is DLCO. What is DLCO? It is diffusion capacity in lungs for carbon monoxide. Clear? So it is, yes, carbon monoxide. Okay. PDF is there in the expansion. Okay. So confused medico, congratulations for passing. You will do best in NEET PG also. Click on the description. In the description, there's a Google Drive link. They are all PDF are there. Now, so if diffusion is problem, we do which test? We do DLCO. What is DLCO? Diffusion capacity in lungs for CO. Normal value is 100%. If it is less than 100, indicates some membrane defect. Like example, acute silicosis. What is the hallmark in silicosis? Ground glass opacity and egg cell calcification of lymph node. Exam में आता है. और which industry? Glass industry. याद करना. Silica किससे बनता है? Glass is again melted. They take the sand. If they heat at high temperature, it melt and become glass. So remember, glass is silica. Then if coal worker pneumoconiosis, it is coal. So coal industry, mining, all. So coal industry, mining, there is this, okay. There's diffuse small nodules, okay, in the upper lung zones, okay, and perilymphatic distribution. Asbestosis involve pleura also. So that's why there's a high risk of our, yes, cancer, pleural cancer. So this cause pleural cancers also, okay. Mesothelioma. So mesothelioma, very important topic. Clear? Yes, Neha, very good. Always focus on your goal, career is very, very important. Rest all is just formality. Are you clear? So that is the story in this case, okay. Chalo. What is it seen in fireproofing industry? Brake lining, insulation. So yaad karna, it is mainly fireproofing. So it was used for fireproofing, tile instruction. Nowadays it is limited use, but still it is very commonly asked in the exam. What are the finding? Cancer. It can cause lung cancer. So cancer plus plaques are there. So pleural plaques are there. Mesothelioma can occur, and there is again ground glass opacity. But axial calcification is seen in silicosis. Now once again we'll summarize. Coal dust, anthracosis, pneumoconiosis, silica, silicosis, okay. Axial calcification. Asbestosis is lung cancer, mesothelioma, asbestosis. Iron is cirrhosis. Organic causes hypersensitivity, pneumoconiosis. Now start with sugar cane. Remember, bag of sugar. So mnemonic is bag of sugar. So sugar is bag, bagosis, okay. Then cotton dust, business. तो क्या है? Textile business. तो क्या business है? Textile business mnemonic है इसका. Very big business. Remember, cotton mills. British came to India to buy silk and वही. So textile. क्या ना, अंग्रेजों भारत छोड़ो, स्वदेशी पहनो. गांधी जी ने बंद किए थे क्लोथ. याद करना. Textile business. So business and tobacco to tobaccosis. And if there is hay or grain dust, maybe farmer's lung. Very common is aspergillosis or actinomyces. Okay, so this is there. Then respiratory failure is two types. What are the two types of failure? Type 1 and type 2. Remember, type 1 only hypoxia. PDF is there in the description. Dr. SIK, click the description, the button more. There you will see the description. Description contain all the PDF. Okay. Chalo. Now type 1, there is only hypoxia. So what is there in type 1? Only solely hypoxia is there. Clear? So what is there? Hypoxia is there. In which condition? So in case of type 1, there is only hypoxia and type 2 there is both hypoxia and hypercapnia. Type 1 is mostly diffusion disorder. Oxygen cannot come to the blood, but person hyperventilate. As the person hyperventilate, CO2 wash out. That's why CO2 level are low. So where is CO2 level high? CO2 level are high in which one? Type 2, because of poor breathing. So which person is breathing poorly? Type 2. Which person is breathing rapidly? That's why his CO2 is washed out. So CO2 is washed out in this case. Are you clear? Done? Chalo. So as CO2 decrease, there is alkalosis, respiratory alkalosis because of low CO2. Here acidosis because of increased PaCO2. So high CO2 cause respiratory acidosis. Then lungs are damaged, so oxygen cannot come to blood. So AA gradient increase because of poor diffusion. Here the lungs are okay, so that's why normal AA gradient. Okay. Now treatment they ask in the exam, so please remember. Okay. High flow oxygen and correct the cause. In this case, avoid high flow. I'm giving it red color. Avoid high flow oxygen because it can increase the PO2 and remove the hypoxia, and that's why it is dangerous. So never ever give high flow in type 2. Type 2 is ventilation. Type 2 is improve the ventilation. How? CPAP, ventilation, or PEEP. What is PEEP? Is positive and expiratory pressure. So we need to correct the respiration. And CPAP. What is CPAP? Continuous positive airway pressure. So what is CPAP? Is continuous positive airway pressure. Continuous positive airway pressure. Next question, type 1, if it stay for a long time, it can become type 2. Why? Once respiratory muscles get fatigued, once respiratory muscles are fatigued, type 1 can become type 2. Example, emphysema is initially type 1. Later it become type 2 because ventilation become poorer and poorer. So remember, that's the case. Now come respiratory failure, type 3. Type 3 is mainly medical procedure called as iatrogenic, very common in peri or post-operative patients. So there's a damage to lung because of again ventilation issue and all, and that's why it is what? It is your peri or post-operative respiratory failure type 3. Whereas type 2, one more variant is there called as type 4. It is basically ischemia, hypoxia of the respiratory muscle like diaphragm. So if diaphragm is not getting the blood, it causes our poor blood flow. Now let's see lung diseases. There are two type of lung disease, restrictive and obstructive. Okay, so I'll write it here. So RLD and OLD, restrictive and obstructive diseases. RLD and OLD. Here, poor compliance. Here, narrow airways. Here, poor volumes, all volume. I discussed that in physiology also. Poor volumes. Here, poor flow rate. PFR, MEFR. So it is PFR and MEFR. So PEFR and MEFR. Yes, लिखा है क्या? कहाँ लिखा? अच्छा लिखा. Okay. मैं बेकार में मेहनत कर रहा हूँ. चलो. So it's here. Okay. So two type of diseases, RLD and OLD. RLD is restrictive, OLD is obstructive. If there is poor compliance, poor recoil, that is called as RLD. If there is a poor compliance but a narrow airway, poor turbulent noisy airflow, example wheezing sound, this is OLD. In case of the OLD, the air cannot come properly, trapping occur. This trapped air causes the increase in residual volume and FRC. We have discussed that all in physiology also. And since the lungs have narrow airway, FeV1 percentage become less than 80% or 0.8 and decrease MEFR, PFR. Whereas in RLD, volumes are poor, but FeV1 percentage is 80% or above, and also normal flow rate. That's why I discussed there are two kind of values. First, if RLD, decrease VC, normal FeV1 percentage. If OLD, normal VC, decrease FeV1 percentage. In mixed disorder, both are decreased. Then there are two type of RLDs. What are the two types of RLD? So they are intrinsic, where lung tissues are affected, like fibrosis, ILD, ARDS. Here DLCO decrease because lungs are damaged. Extrinsic is problem in chest wall. अगर chest wall खराब है तो movement नहीं होगा, like GBS, myasthenia gravis, ankylosing spondylitis, costochondritis or kyphoscoliosis. Here DLCO is normal because lungs are okay. The chest wall is the problem. So remember, chest wall problem is our extrinsic. Lung problem is like fibrosis is intrinsic restrictive lung disease. Intrinsic restrictive lung disease. Now remember, obstructive lung diseases are two types. What they are? They are our, yes, reversible or irreversible. If you give a beta 2 agonist like salbutamol inhaler, we give the puffs, and now if the person show good response, there is decreased wheezing and airway dilation, it means it's a reversible like asthma. Whereas COPD problem is irreversible. So even after taking the inhaler, the response is poor. That is why it is irreversible obstruction. So which obstruction? Irreversible obstruction is the term. Okay. Then in COPD also there is blue bloater, okay, or pink puffer. So blue bloater, there's a chronic bronchitis, BABA, and pink puffer is emphysema. So blue bloater and pink puffer. So yaad kar lo. Now we'll discuss the first obstructive disease, which is asthma. It is type 1 hypersensitivity, in which there is an allergic reaction. Airway are very hyper responsive. Even smallest of the trigger can activate the severe bronchospasm, which cause wheezing. So what is there? Trigger are basically antigen or allergen. Pollen are very common. Could be dust, aerosol, or any organic material can be there. Now they bind the IgE on mast cell, MCQ, and now the eosinophil and mast cell release. What they do? Release histamine and leukotriene. Which one? All chokas. C4, D4, E4. C4, D4, E4. C4, D4, E4. Once there's the release of all this C4, D4, E4 histamine from mast cell and interleukin. And one more question. Who is the interleukin for eosinophil? Letter E is fifth letter, na? E is fifth letter, E is fifth. So interleukin is fifth. भूलना नहीं है. eosinophil का interleukin 5 है. ठीक है, चलो. Bronchoconstriction is there, which cause wheezing, breathlessness, chest tightness, suffocation. And what is wheezing? So wheezing are basically musical sound. So what is wheezing is? So wheezing is musical whistling sound which are heard in expiration. Are you clear? Then when you do a examination by taking a biopsy, you see airway inflammation is there. Infiltration, that is the airway are filled with WBC, especially eosinophil. Mucosal edema will occur because of inflammation. Hypertrophy of muscle is a hallmark. 3 findings, CCC. So triple C, CCC. So that is Charcot Leyden crystal, Crushman spiral and Crayola body. So you can remember a mnemonic. 4 people beat you. 4 लोगों ने कूट दिया और क्रश कर दिया मैन की बॉडी को. And now it's crying and take a ola. Cry ola, cry ola, Crayola, cry ola, Crayola. So this is Charcot Leyden, is made by galectin 10. It's long needle-like structure. Can you see this? This structure, this needle-like structure is our galectin 10 Charcot Leyden crystal. Then we have this long, like spiral like structure. This is called as Krushman spiral. Okay, they are all in sputum, and this is the ink blot like Crayola bodies. Okay, now asthma is basically two type. Intrinsic is non-allergic, extrinsic is allergic, mainly occur in E. Allergy means you are allergic to your X ना, तो याद करना X से allergy है, X से allergy है, and X क्या है? अर्ली लाइफ में आपको बर्बाद कर चुके हैं. सो अर्ली, सो चिल्ड्रन हैव एक्स. ओके, और मे बी योर एक्स ऑल्सो है चिल्ड्रन नाउ. ओके, चलो नेक्स्ट क्वेश्चन. इट इज टाइप 1 हाइपर सेंसिटिविटी, ट्रिगर इज एलर्जन. इट इज मोर कॉमन. नाउ इंट्रिंसिक इज लेस कॉमन and it is non-allergic, so it's not having a allergic, like history, patch test, etc. not positive. Now it occur in late life, okay, like adults. Okay, so these adults have a history of respiratory infection. Like I had lots of respiratory infection as a kid. Now my airway are hypersensitive, so when I am exposed to, let's say, exercise, cold air, drug, I develop sometime wheezing. So this is intrinsic asthma. So don't have 24/7, but only there are some condition which can cause wheezing, like pollution. I go to some area with lots of pollution, I start feeling suffocating, and yes, I have wheezing. So that's why sometime when I go abroad, I am not having that much. But when I come back to India, especially Delhi, when I land, sometime I start having wheezing episode. Again, it's intrinsic asthma. Now, clinical variation are सबसे पहला we are discussing is seasonal variation. What is the funda about seasonal variation? That means they occur all the time or there is some specific timing. So obviously it is occurring more when the pollen are more. Like example, spring season. Like example is spring season, you can get lots of pollen produced, so that's why it's there. Then there's recurrent attacks of wheezing, dyspnea, cough. Cough is there but less sputum. Remember, sputum is highest in case of bronchiectasis and bronchitis. Remember, chronic bronchitis. Then exercise is not possible because it triggers the wheezing. Very easy to get tired, fatigability. Okay, chest tightness, suffocation, poor exercise tolerance is there. Then tripod position, that is sit with hands only like this. Okay, like I am sitting. This is tripod position. Even athlete after running sometime take tripod. It improve the ventilation. What is the benefit? Improve ventilation. So when you do a tripod, it help you breathe better because it cause the freeing of the upper chest to move more, and that improve the ventilation. Okay, so that is the finding. Okay, check. Next question, right? Also exertion worsen the problem. That's why the advice is do slow and deep breathing, don't do rapid breathing. Okay, next question is investigation, spirometry. We will get a normal compliance and normal recoil, this is not the problem, but there is decrease FN percentage, RV FRC increase because air is trapped. It causes mostly type 1 respiratory failure and there is respiratory alkalosis. Severity is very easy, 80, 50, 30. What are the criteria? 80, 50, 30. Let's do that. It's very similar here. 80 is 50 plus 30. So that is the very simple criteria. 80, 50, 30. So 80, 50, 30. So 80, 50, 30 is the criteria. So 80, 50, 30. So clear? So 80, 50, 30 rule is there. Now let's start. ठीक है, चलो. So less than 80 is mild, moderate less than 50, severe less than 30%. So what are the criteria? It is 50 to 79, 30 to 49, and it is less than this. So that is 29 or less. Okay, so 29 or less. So please don't forget, it is very, very, very important. Ask in the exam. Now how do you do the self monitoring? So we give something called as the peak flow meter, and patient can do self monitoring by right peak flow meter. It look very similar to our Shaki tape. We ask the child to blow air into the machine and check the reading of the meniscus. If it goes to the green zone, it is normal. Red means it is poor. So that's why it can give the values whether it's normal or abnormal. This is called as our right peak flow meter. For the normal value, it's 250 to 500. So what is the value? 250 to 500 liter per minute. So 250 to 500 liter per minute. And it is a self-monitoring device. So what device? Self-monitoring. Next question, PFR is low in small airway obstruction. So if there is a small airway obstruction, it is decreased. Okay. Now we'll discuss the classification. If less than 2 or 2 days are affected in a week, it is intermittent, or less than 2 nights in a month. If more than 3, it's persistent. 3 to 6 days a week is mild, like almost every day except 1 or 2 days. If not there, it is mild. If daily, is moderate. So Modi ji रोज आते ना, daily he comes on the TV, moderate. Modi ji moderate, and severe is severe, multiple attack in a day. Now what is the management treatment? First we do is avoid exposure, like wear the mask, etc. Avoid exposure, wear mask. Then patch test. What is the funda about the patch test? It identify the allergen. Okay, so we apply all known allergens as a patch on the back, and the one showing the redness, that is erythema, is yes indicative the person is allergic to this particular condition. So that is your redness, erythema, if sensitive to that particular allergen, and now avoid them, and then we avoid them. Okay, so next question. Prophylaxis. Okay, remember prophylaxis is basically before the attack, to prevent the attack from occurring. So Lee, remember mnemonic, Lee is lower the immunity. What is Lee? Is lower the immunity. तो कैसे याद करेंगे? Monoclonal antibody. Okay, कौन सी? Against okay, against IgE is ओमालीजुबाब, इंटरलुकिन 5 इज मीपोली और रेस्टली. तो उसका निमोनिक याद कर लो. गार्डन में गए, ठीक है, गार्डन में, और क्या बोला? ओ माली. तो बच्चा क्या बोला चिल्ला के? सो बच्चा क्या बोला? ओ माली. मी पोली एलर्जी. एंड वो पूछता है क्यों आया? रसीला आम. तो क्या बोल रहा है वो? मी पोली, पूरन पोली बनाऊंगा, पूरन पोली, और क्या खाऊंगा? रसीली आम. तो याद करना, ओमाली, पोली और रसीली. ओमाली, मीपोली and रसली जुमाब. Then we can give mast cell stabilizer. The mnemonic is कोली बेटा मस्ती नहीं, मस्ती ना करो. So मस्ती. So mast cell stabilizer are CRO drugs. CRO. So मस्ती करो CRO drugs like sodium chromoglycate and nidochromyl sodium. Sodium symbol is Na. So ना करो मस्ती. Then we can give leukotriene receptor antagonist Latra. What is this? LTRA. जफ्फी, लुकास, मोंटी, लुकास. तो दो दोस्त थे, जफ्फी और मोंटी, या मोंटी ने जफ्फी दी, तो मोंटी जफ्फी देता है. चलो. Then we can give lipo oxygenase inhibitor. What they prevent? They prevent leukotriene formation. What they prevent? Leukotriene formation like Ziluton. Now we also have the antihistaminics. They are cetirizine, levocetirizine like estimazole, ketotifen-terfenadine. They are antihistaminics. Okay, and finally comes the controller. Controller are the drugs which are used to decrease severity. So what decrease the severity? Controller. So what decrease the severity? Controller decrease the severity, and they are basically steroids. MCQ. Steroids are the controller drugs. Okay, they are anti-inflammatory, decrease the inflammation, and that's why they are the best, because if you decrease the inflammation, then the features of asthma will be reduced, and that's the case. Now there are 3 types of steroid we use: ICS inhalational, OCS oral, and IV steroids. What we use? IV steroids. Now, what is the example and the story? So first question, ICS is for mild to moderate asthmas, inhalational. Oral is hydrocortisone, mainly used in severe, and if you give IV hydrocortisone, it is in severe asthma. So which condition? It is in, yes, status asthmatica. So remember, mild to moderate, we can use inhalational. Severe, we go for oral steroids. And if it is IV, it is status asthmaticus. Now, oral or IV steroid, there's a high risk of Cushing syndrome and less in inhalational form. That is why they are the most preferred form. So, inhalational example are budesonide and fluticasone. Fluticasone, they are coming as inhaler, and these inhalers release the drug in the vapor form, aerosol vapor form, and they are only for local action. So, that's why they have less risk of Cushing. MCQ. So, where is high risk? It is obviously oral and IV. And what is less risk? It is the inhalational. Side effect. If there is a oral effect, it can reduce the immunity and increase the infection by Candida. So oral candidiasis risk increase. Drug of choice is clotrimazole we can give. So clotrimazole is given for candidiasis, and prevention is rinsing the mouth. Like you take the inhaler, then you and yes, we will rinse and yes, throw the fluid so that the airway are clean, upper airway are clean from the steroids. MCQ. This is exam question. Okay. So are you clear? I said na, inhalational steroids are not given status asthmaticus. We give IV. Okay, Roy? We are giving IV. Okay. Now relievers are bronchodilator. They are used in attack. So when there is an attack, we give bronchodilator. There are two types, Ma or Ba. So Mama or Baba. Mama, Baba, Ma, Ba. Ma are muscarinic antagonists. Which one? They inhibit M3 and cause bronchodilation like ipratropium, tiotropium. I covered that in my pharma session. You can watch it if you want. After class, I will give you link of all my race sessions so that if you have time, you can watch them like binge watching होता है ना Netflix. वैसे देखो और खत्म कर लो. अब आ गया हमारा बीटा 2 एगोनिस्ट बा क्या करता है? ब्रोंको डायलेशन. बा ब्लैक शिप क्या करता है? बा ब्रोंको डायलेशन वाया स्मूथ मसल रिलैक्सेशन. एग्जांपल साबा, लाबा. साबा इज शॉर्ट एक्टिंग, बूटा लॉन्ग एक्टिंग आर मीटर और मोटर. So if the name contain buta, it's a short acting. Boot is for short distance and meter or motor is for long distance. So salmeterol, formoterol, arformoterol, dacterol, inducterol is the longest acting. So which is the longest acting amongst them? It's inducterol. So it is inducterol is the case. ठीक है? चलो. Thank you very much, Dr. Roy. But the main thing is I'm trying to cover as much as possible. Now, management as per the GINA 2019 guide now been updated to 21. I'll discuss. For attack, we give a reliever. So if there's an attack of asthma, we are going to give this. Okay, so relieved. So we give the what drug? We give the Saba. And if not relieved or more attacks, then if not relieved, then we go for LABA plus ICS. Mild or not relieved by SABA, then controller and low dose ICS started. So what do you start initially? Initially, no steroids are needed. Only reliever is sufficient. So initially, only reliever, which is SABA, and if needed, low dose ICS plus LABA, but no need of steroid. Later, we start with low dose steroid. What steroid? Low dose. Then we can give daily low dose steroid or medium dose or high dose. So we are going from low to medium, medium to high. If still not control, we can add LAMA or biologics. What is biologics? They are all Latra drugs or MABs. They are biologics. And last treatment, last is OCS. So last treatment is OCS. If no drug is successful in controlling, we can go for oral steroid. So are you clear? So initially start with our reliever, SABA or ICS plus LABA. If not improving, we can add daily low dose ICS. Then we can go for medium dose ICS. Finally, we can go for high dose ICS steroids, and we can add LAMA or the Latra or MAVs. And last treatment, final treatment is OCS. If nothing work, we go for OCS. So nothing, then OCS. Thank you, Dr. Roy. This time also I'm telling you, okay, if anyone do this PDF, I can guarantee you 70% question of any exam, NEET, PG, FMG will be solved. Again, वही बात है ना, क्या बोले हम, मतलब people, you cannot explain them, okay, like you tell them do exercise, get up on time, or drink lots of fluid, don't drink alcohol, but they will ignore, they will not listen to you because they're not getting pleasure in that, okay, and they will do other things which give them pleasure, although they are also not good. Reason, again, it's just, what do you say, hard behavior, okay. If others are also doing, chalo yaar ye wala revision dekh lo, ye wale session kar lo, ye RR, so all will be doing that, no one will be going for anything else. वही hard mentality वाली बात है. So that's why I'm telling you, okay, you do this after exam, tell me were they effective or not, and then we'll decide they were effective or not effective. Now status asthmaticus. In status asthmaticus there is minimum breathing, so breathing is very reduced and chest movement is also be yes. Chalo, okay, I don't know, Krishna, what can I say? Again, every Indian only act when they are forced to act. Indians are like cows. A cow sitting will not move till you push them. That's why Indians have high inertia. They have the highest amount of inertia. If they are not doing something, it's difficult to make them do. And if they are doing something, very difficult to make them stop. Clear? So Indians are one of the highest inertia people. Chalo. Fine? Chalo. Okay. Let's continue. Now, what do you give? Nebulization. So we give the drugs through nebulization. Which drugs? We give salbutamol, ipratropium. Nebulization is basically we heat the drug, so it becomes vapor which are then inhaled. Then 100% humidified oxygen, not dry oxygen, plus IV hydrocortisone, IV theophylline. They cause bronchodilation, plus also the subcutaneous terbutaline. These are given. Okay. Now, what is Brittle's asthma? It is an asthma which has poor response to the usual treatment and a very high morning evening variation in the PEFR, peak expiratory flow rate. Treatment here is steroids and catecholamine, especially adrenaline. So if you are giving adrenaline, which asthma is this? Answer is Brittle's asthma. Now COPD. COPD is related with cigarette smoking, okay, plus there is a chronic inflammation and obstruction. What is there? There is a chronic inflammation and obstruction taking place. So what is there? Chronic inflammation and obstruction, plus there is cough with lots of sputum and mucus production is there. Now we can classify into two conditions. One is our chronic bronchitis and emphysema. So remember, in bronchitis there is more airway problem, less diffusion problem. In emphysema, less cough sputum, less airway problem, but more diffusion and hypoxia. So what is more diffusion hypoxia problems? Emphysema, less cough sputum. Where is more cough sputum? It is chronic bronchitis. Now what are the criteria for diagnosis? For chronic bronchitis, the criteria is lots of sputum and cough which is more than 3 months for 2 consecutive years. So अगर याद करो 3 months से ज़्यादा cough है with lots of sputum, continuous sputum, it is chronic bronchitis. Okay. Hypoxia, barrel chest is more seen in emphysema. Now let's see pathophysio. Smoking is the root cause of COPD. Smoking damages the epithelium, can cause metaplasia and even squamous cell cancer. MCQ. Then mucus production is there, which causes increased goblet cell, mucus gland hyperplasia, which is the result of what? Irritation by the smoke. So you react by making sputum, and this sputum or mucus is then the thing which is coming again in this person. Then what happens is there's a cilia damage because of epithelium or ciliary loss, and the mucus which used to move from lower airway to upper and then cuffed out cannot move. So sputum accumulation occur and this mucostasis accumulation is called as reduced mucociliary clearance. So normally cilia move, now it can't move. Can you see? So normal airway with the columnar cell and their cilia, they are moving the mucus in a escalator mechanism. Airway is very well dilated. Now if there is increased mucus, damaged cilia, hypertrophy of the muscle, and also extra mucosal gland and goblet cell, this causes our mucus plug, obstruction, and also infection. Because whenever there is a mucoid accumulation, bacteria grow very well. It acts as a culture media and increase the bacterial growth. Okay. Next question. So all this cause the airway obstruction. The diagnostic criteria we use is Reed index in this case. What is index? If you take a ratio of the wall thickness of the total, yes, bronchial, this epithelial wall till the, yes, our this cartilage, this is our wall. Now in case there is glands more than 40%, that is 0.4, it is indicative of hyperplasia of the gland. Normally these glands are less than 40% of the total diameter. If they become more than 40%, then it is your increased Reed index. So this is the case. More glands, more mucus. Can you see the green is mucus and this green are glands. These are the glands which are increased. So what is index? It is more than 0.5 or more. So 0.5 or more is our diagnostic criteria. Yes, more than sufficient, Vikrant. Just do it. Okay. Clinical features. So remember, productive cough is what? More than 3 months. So more than 3 months with copious sputum, cyanosis is there, clubbing is there, plus right heart failure. I told you already, because of lung disease called as cor pulmonale. Then there is respiratory infections a lot. Then wheezing and rhonchi. Wheezing is obviously because of spasm, airway narrowing. Rhonchi are wet sound due to airway secretion. So they are khad 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 khad, like wet sound, fluid moving. Then dyspnea and tripod position. This I discussed in asthma also. They are younger patient, 40-50 year compared to emphysema, which are 50 to 70 year. And finally, they are very obese. So obese, 40-50, they all are seen in the case of emphysema. Then type 2 respiratory failure is more common compared to type 1. Okay. And this is our wheezing, pursed lip breathing. This is pursed lip breathing, but it's mainly seen in emphysema. Pursed lip emphysema. So pursed lip breathing is seen mainly in the emphysema. So pursed lip breathing is seen where? It is seen mainly in the case of our emphysema. Okay. Okay. Then come our investigations. So investigation, we do PFT, and what is obvious, we see decrease FeV1 percentage less than 80%. So how much is the FeV1 percentage? Obviously it will be low. It is much low, below 80%. So the value is below 80%. So clear now? So below 80% is the value. So clear? Okay. Then also what is normal? Lung recoil compliance DLC are normal because lungs are not affected per se, alveoli. What is affected? Airway are affected. So what is affected? Airway are affected. Then as there is an increased thickening of the airway, you see prominent bronchovascular marking, maybe right heart changes, like what? Yes, right heart changes. What? Hypertrophy can be there. Then this dilated lungs also, all can be seen. Then treatment is quit smoking. Remember, always bronchitis, which is due to smoking, main treatment is not drugs, but quit smoking. Drug of choice is varenicline is given. Okay. Earlier we used to use bupiprine also, but nowadays we use varenicline. Then LAMA, steroids for obstruction, antibiotic for infection, and mucolytic, which clear the airway by breaking the mucus. Bromoxine, bromoxol, and acetylcysteine. But best is quit smoking. That is the case. Quit smoking, quit smoking, quit smoking. Then come emphysema, very important disease. First is emphysema is acquired due to smoking, pollution, or can be congenital. It's a genetic disease, autosomal recessive. So remember, it is serpine gene 1 defect on chromosome 14 which cause congenital emphysema. Smoking, pollution cause acquired emphysema, mainly elderly people, 50-60 years. What is the deficiency in congenital? In congenital, there is a alpha-1 antitrypsin deficiency. So what deficiency? Alpha-1 antitrypsin deficiency. It's a congenital one. And lungs have what? High compliance and recoil because of which protein? Elastin. So elastin is broken down by elastase. So if there's a alpha-1 antitrypsin or TIMP is tissue inhibitor of metalloproteinase deficiency. So if there is what? Alpha-1 and TIMP, they break down the elastase and prevent breakdown. So if there's a deficiency of TIMP or alpha-1 antitrypsin, there will be increased breakdown of the elastin. So let's see the pathophysiology now. Smoking increase the elastase. Alpha-1 antitrypsin deficiency again causes increased elastase. So they all cause a increased elastase. Why? Because alpha-1 decrease elastase. Alpha-1 decrease elastase. As elastase increase, it break the elastin, so recoil will decrease, compliance will increase, and that is what emphysema is. Okay. Then there is poor expiration because the person cannot breathe out because of the poor recoil. So air get trapped in the lung. As the air get trapped, okay, it causes the lungs to become very big, expanded. Then this chest tightness, suffocation is also there. Plus there is a decreased recoil, increased compliance, so the lung become very big and dilated, especially at what level? Asinus level. What is asinus? It is single respiratory bronchiole and alveoli supply. It's called as asinus. So this is asinus. Let's see this. So this is our asinus, normal asinus, starting with the respiratory bronchiole and all alveoli it supply. Look like a grape or branches of tree. Now, if there is a dilatation, it could be in the central part, centry, or it could be all of this. It's called as pan-acinar. So pan is all, pan is all, pan is all. Okay. Now comes the question, what is the other story? Let's see. What is the most common type? Centry acinar is the most common, which is by smoking. So CC, cigarette cause centry in the center. And pan, parents give pan is parental, that is genetic. Alpha-1 antitrypsin, parent से कौन सा आया? pan acinar. Next question, dilated acini also produce subpleural bulla or blebs. So it produce below the lungs, bulla or blebs. It ruptures, leaking air into pleural cavity. So where the air will leak into pleural cavity, which can cause a pneumothorax, called as closed pneumothorax. This is the bleb or bulla. Plus the hyper inflated lungs push the chest forward, causing the barrel shaped chest. So what chest is there? Barrel shaped chest is there. Also, just like chronic bronchitis, there is airway inflammation, increased mucus, edema, poor mucociliary clearance. All these changes are there, which cause irreversible obstruction. Which obstruction? Irreversible obstruction. Plus what? Plus there is less cough and less sputum. Clear? So less cough and less sputum is there. Now also the damage to lung, alveoli, capillary, so that's why diffusion become poor, and poor diffusion cause hypoxia, plus the person will compensate the hypoxia by making more RBC. That's why there is a pink skin, so called as pink puffer. And as patient hyperventilate, the lips are very narrow, that is called as purse lip breathing. Also there is initially type 1 failure, later it can become type 2 because of extreme expanded lung. Now they are so big, they have unable to move further, and that is why there is type 2 in advanced cases. So the advanced emphysema, type 2, initially type 1, okay. See, barrel chest will be seen in obviously emphysema older patient. If congenital, you can see barrel chest in child also. Now clinical feature, they are older compared to bronchitis, thin person with pink puffer, barrel chest, less cough, less sputum, less infection, less, like respiratory airway problem. But there is more problem in terms of breathing. So dyspnea is more more dyspnea, more suffocation, pursed lip breathing, and cor pulmonale is less common compared to the bronchitis. Then there is effort intolerance. He get breathless very easily. Even ordinary or less than ordinary activity cause severe dyspnea. That's why blue blotter is cyanotic cough sputum, cyanotic cough sputum, and pink puffer is pink because of RBC, pursed lip breathing, and barrel chest. So these are the findings. Barrel chest. Okay. Done. Okay. Next question on examination. So when you do a percussion, high resonance is there. Why? Because lungs are full of air. So high resonance is there on percussion. And if you do X-ray, you see hyperinflated lungs. That is, the lungs are very filled with air. So hyperinflated lung, hyperlucency is there. Also, low lying flat diaphragm. Diaphragm is pushed downward and flat. So this is a flat diaphragm. The heart appears small, and called as vertical tubular heart. So these are findings. So the X-ray very black, that is called as hyperlucent. Then next question, in PFT obviously flow rate will decrease, FEN percentage will decrease, VC also decrease. That's why it's a mixed pattern. Okay. High RVFRC because of the air trapping, flow rate is poor, so decrease MAFR. High compliance, poor recoil, decrease diffusion, so DLCO will decrease. In case of bronchitis it was normal. And also high VQ because of VQ mismatch. Okay. Severity of the COPD is by gold criteria. It is very similar to asthma. What are the gold? If grade 1 more than 80%, grade 2 is 50 to 79, grade 3 is 30 to 49, grade 4 is less than. वो ये less than 80, less than 50, less than 30. 80, 50, 30, same as asthma. So similar to asthma. Okay. Treatment is similar. So the treatment almost exactly same. क्या करना है इसमें भी? Yes, we will give stop smoking, then LABA, LAMA, steroid, mucolytic, antibiotic, but main is stop smoking. Then we can do surgery. We can remove the excessive inflated bullas, or lobes can be removed, even one side lung, because lungs are so big they can't move. So need to remove one side of the lung or the lobe so that there is increased space for lung to flow. So last stage is lung transplant, that is on the base of BOD index. What is BOD or body index? It is BMI, obesity, dyspnea, and exercise capacity. If it's very worse, we go for surgery and lung transplant. Bronchiectasis. Now what is bronchiectasis? It is an irreversible airway obstruction with dilated airway. याद करना, it is called as ectasia because the airway are dilated. It is mostly seen after airway obstruction. So there is initially what problem? Airways are obstructed. If there is a airway obstruction by infection, tumor, foreign body, etc., we will have the dilated airway behind that. So what happens to airway behind that? They get dilated. There's also destruction of airway cilia, plus there is what? Increase mucus. So mucus will also increase. So all these are the findings we will discuss, and this clear? Chalo, okay. Let's continue. Sorry, I have a flight to Ahmedabad today. I'm going to Ahmedabad for classes. Yeah. Chalo. Next is also, remember, in India, what are the most common cause? It is TB, and this is called as bronchiectasis sicca. So TB is most common in India as a cause of what? Our bronchiectasis sicca, that is bronchiectasis. In developed countries, cystic fibrosis. What are the most common cause in developed countries? It is cystic fibrosis. Also seen in Carter-Jenner syndrome. So which syndrome? Carter-Jenner syndrome. If tumor is there, it's called as focal bronchiectasis. Otherwise, it's a diffuse bronchiectasis. Like in cystic fibrosis, you'll get a diffuse Carter-Jenner diffuse. Now, this was asked in last year exam, both INICT and also FMG. What is Carter-Jenner syndrome is? It's a defect in a protein called as axonymaldinin. It's a molecular motor help in cilia motion. Without the dynin, the cilia and the motion of sperm is gone. That's why infertility occur. Situs inversus, that is organs are on the opposite side. Example, heart on right side called as dextrocardia. Treatment, there's no treatment as such, but we can give mucolytic antibiotics. What are the clinical features of bronchiectasis? There is productive cough, lots of cough with lots of sputum which contain pus, that is neutrophil WBC. Then there is recurrent respiratory infection. So there is fever, cough, hemoptysis can be seen. So what can be seen? Hemoptysis can also be seen. Plus there is cyanosis, dyspnea. So cyanosis and dyspnea is also occurring. Okay. So it resembles bronchitis, but there is a dilated airway. So remember, bronchitis has smoking and read index all, but dilation of airway is not seen. If this dilated airway, suspect our bronchiectasis. Now, PFT again decrease because I told you it's similar to our bronchitis. Then if you are suspecting TB, we can do culture, X-ray, CBNAT, or yes, our sputum examination. Then X-ray, CT, always use HRCT for best appearance. We see dilated airway giving a pearl ring appearance. क्या बोलते हैं इसको? Signet ring. ऐसा लगता है pearl की ring है with black hole and the white pearl. This is called as signet ring appearance. Okay. Also we can see tram track appearance. So signet ring, tram track, railway patri appearance is seen in HRCT. Treatment, we give antibiotics, mucolytics, वही LAMA, LABA, chest physiotherapy to clear the airway, and main is we can give vaccine antibiotics to prevent infection. If TB, ATT, that is covered in pharma. ATT I have covered very well in pharma, and micro covered the TB also. This is the general summary. Now we'll do pneumonia. What is pneumonia? Pneumonia is the inflammation of lung parenchyma. There are three main categories: nosocomial, community acquired, or VAP. What is VAP is? It is ventilator associated pneumonia. What is VAP is? VAP is ventilator associated pneumonia. Are you clear? Fine. So ventilator associated pneumonia is there. Just 1 second, okay. Let's continue. Now, what is the first category? First category that we see or have is our HAP. What is HAP is? It is hospital acquired, earlier also called as nosocomial. Okay. It occur after 48 to 72 hours of admission. If pneumonia occur after 48 to 72, it is called as HAP. CAP is community acquired. Community acquired will occur before hospital admission. So it occur before hospital admission, that is 48 to 72 hours before admission. Okay. So remember, if it occur after admission of 48 to 72 hours, it is hospital acquired, otherwise community acquired. Then come VAP. VAP is ventilator associated pneumonia. It occur after intubation 48 72 hours. So intubation is the case. So intubation. Second question, what is the most common? It is Klebsiella, which is again hospital acquired infection. Most specific is Acinetobacter. Acinetobacter. If Acinetobacter they are giving, suspect VAP. If they are asking what is causing the VAP, Klebsiella. If drug resistant, go for Pseudomonas. Now, bacterial. CAP, the most common is Streptococcus, H. influenza, Chlamydia, Moraxella, Coxella, viral, etc. They all are CAP. Hospital acquired are mainly drug resistant, and if they're asking, the most common is Pseudomonas or MRSA. MCQ. If non-drug resistant, they are similar to CAP, like pneumonia, influenza, mycoplasma. So remember, CAP में most common Streptococcus, फिर mycoplasma, virus, chlamydia, all. HAP में Pseudomonas or MRSA, VAP is very again similar, Pseudomonas, MRSA, and Acinetobacter. Acinetobacter. Now, viral influenzas, viral pneumonias are influenza like bird flu, swine flu, H1N1, H5N1, COVID-19, very common recently, and adenoviruses. So, what viruses? Adeno-rhinoviruses. Now, let's see. If there's a history of exposure to bird and pigeon, bird is chidiya, Chlamydia, Chidia, my India, chidiya, and they sit, pigeons sit and do shit. तो पिजन क्या करते हैं? गाड़ी पे, ये कार खड़ी है ना आपकी, तो भाई साहब कार की मां बहन एक करता है ये कबूतर. तो अगर किसी की कार है तो कार का कौन बैंड बजाता है? आपका पिजन. तो क्या करना है? क्लमाइडिया सिटाकोसिस. सो सिटाकोसिस, पत्थर मारो साले को, अजी थ्रो आ स्टोन. सो अजी क्या बोला? अजी मारो साले को पत्थर, अजिथ्रोमाइसिन. क्या दोगे? अजिथ्रोमाइसिन. अजिथ्रोमाइसिन. देन होटल, क्रूज, एसी, हु गो देयर? लैला. So Lala go there for shooting of movie and song, selfie. So Lala वहां गई, Lala, Legionella, Lala, and it caused Legionnaires disease. Okay, और उसको भी क्या करना है? पत्थर मारना है, azithromycin. HIV most common is strep pneumoniae, but opportunistic infection will be pneumocystis yarovesi. Okay, or carinide, Giemsa stain. Drug of choice is Cotri, Moxazole. If sheep and goat exposure is Coxella burnetii, doxycycline plus hydroxychloroquine is the grip. Alcoholic most common is strep pneumoniae, but if aspiration occur or intubation occur, aspiration, intubation, then Klebsiella, which show red currant jelly sputum, red currant jelly because of RBC, also called Friedlander's pneumonia. Atypical is caused by viruses or mycoplasma. Viruses or mycoplasma, they give fried egg appearance. Drug of choice doxycycline or azithromycin. Clinical feature, high grade fever with chills and rigors, then severe dyspnea, high respiratory rate, cyanosis can occur, then chest pain is there. Chest pain is the hallmark. Fever, chest pain, suspect of this. Cough with grayish purulent sputum because of WBC inside. Blood can come, so that's why RBC can be there. Examination, lungs are consolidated because of inflammation fluid inside. That's why dull percussion. So when you percuss, the sound is less. Increase vocal parameters. When you say 1 2 3 1 2 3 1 2, this is called as vocal parameters. So when you compare the sound, it is more, and also reduce chest expansion. Bronchial breathing is heard. So what breathing is there? Bronchial breathing, which is very loud and high pitch. Loud and high pitch. And also crepitation and crackle. So crepitation are sounds which are because of air fluid. So crepitation. Now, three type of pneumonias are there. Lobar involve the whole lobe, entire lobe. Dense consolidation, unilateral, and there is the air bronchogram. What is air bronchogram? You can see the airway inside the consolidation. So you can see the entire bronchial tree is called as air bronchogram, mostly caused by strep pneumoniae. Strep pneumoniae, Klebsiella. Then come broncho. It is bilateral, both sides. Patchy opacities are there. So what is there? Patchy opacity. So what is there? Patchy opacities. And there is Staph aureus, chlamydia, H influenza. And interstitial involve the interstitium of the lung. Bilateral diffuse opacities, which are called as ground glass opacities, very common in COVID-19. So COVID causes ground glass appearance. Okay, so viruses, mycoplasma, pneumocystis yarovesi causes our ground glass. This is the ground glass. I'll show you. Now, Atypical are virus mycoplasma, less features. So remember, less features. And typical are bacterial, high grade fever, more features. Then there are 3 stages of lobar pneumonia, congestion, in which there is the increased vascularity, blood flow within 1 to 2 days. Then there is consolidation. The lung look like liver. Hepatization is there. Initially it is red because of RBC. Then RBC breakdown. So color become gray. So call as gray hepatization. Lastly, there is repair healing, called as resolution, which occur after 1 or 2 weeks. Now investigation, we do X-ray, HRCT, sputum. We can, if no sputum, we can do bronchoalveolar lavage to get the sample. RT-PCR if you're suspecting COVID-19. Viruses, we can do antigen test or PCR. See, PCR is for DNA virus. RT-PCR for RNA virus. ये सबको पता होना चाहिए. चलो, बाकी CBC, ABG, SpO2 all should be tested. Now the treatment. Treatment is 100% exam question. ये आ रहा है आपका curb 65. What is curb 65? Confusion, uremia, respiratory rate more than 30 or BP less than 90/60 or age more than 65. C for confusion, because brain not working, getting oxygen, kidney not working, so uremia occur, burn increase more than 20 milligram percent or 7 millimole, rate is more than 30, like he's doing rapid breathing, or BP decrease, that is heart is not getting enough oxygen, or age more than 65. Now each parameter score is 1, so total score is 5. If 0 to 1, we can treat in the OPD with antibiotics. If score is 0, 1, 2, 3. Now remember, 2 or 3, we admit the patient and give antibiotics. Even if score is 1, we can admit. And if it is 4 or 5, ICU intensive care. ICU intensive care is to be given. Okay. So I will end the session here. I have covered all important. TB I'll cover in patho and pharma and micro. Tuberculosis, rest all has been covered. So I'm ending the session because I have flight, so I'll go there. So I'll take session now on, not tomorrow because tomorrow I have whole day class, on 15th, 16th, 18, 19, 20, 21, 22. So these are the days we'll have the other race sessions, longer sessions, and we'll cover our recommended subject. Okay? Yeah, so next session will be 15th of time will be 7 p.m. Chalo. So I will upload this file. Yeah. Chalo, okay? So I'll upload. Okay? I'll discuss it. Don't worry. Okay? Chalo. प्रदीप समझा कर यार, सिलेबस खत्म करना है, हंसी मजाक तब करेंगे ना जब टाइम होगा, टाइम ही नहीं हमारे पास, बहुत हेक्टिक चल रहा है. चलो, आई विल फिनिश. टेक केयर, बाय बाय. सो आई विल रश. विल मीट सून. टेक केयर, बाय बाय.